abstract. Treatment of bifurcation lesions with novel drug-eluting self-expandable Stent Axxess, single-center first experience.
Dear panelists, moderators and colleagues, it's an honor to be in front of you and to talk about this issue, the bifurcations and dedicated stent. As we saw in this session and many other sessions, the bifurcations are the sessions with much questions, because there is not one technique and there's a lot of techniques, different methods. So one of the techniques is this type of dedicated stent, especially Axxess, which is, let's say, dedicated bifurcation stent. It's a self-expandable platform which is not very familiar to, now for our work as an interventional cardiologist who do peripheral artery, maybe yes, but who do only interventional cardiology. Self-expandable stent is a little bit difficult and different to place it in the bifurcation. It's a drug-eluting, one of the rare bifurcational stents, drug-eluting Biolimus A9, biodegradable polymer and a luminal coating, something like a biomatrix as a platform. So the characteristic of Axxess is the stent is that goes toward the bifurcation without touching the carina, and as we know, the carina is less co-involved or involved in the atherosclerotic process. So the flow toward the carina main branch and side branch remains unalterated by the stent placement. As objectives, our aim was to share our first experience with this self-expandable drug-eluting bifurcational stent among the friends and experts, to report our procedural outcomes, immediate outcomes of these patients undergoing treatment of bifurcation. So we treated 20 patients with Axxess stent almost in 1 year. As a patient population's risk factors, the population was really very heavy according about the risk factors, because almost 95% were with hypertension, 80% with diabetes, dyslipidemia, 70% smoking, obesity, familiarity, and patients with more than two risk factors were 95%. About the study clinical characteristics, we had about 55% patients with previously done angioplasty, and the stage PTCA in this group was about 70% as we were getting experience. Now we are placing Axxess ad hoc, let's say, during the procedure, but at that time we were getting experience, so we selected the patient for Axxess, thinking very much now, not saying that we're not thinking now. So something interesting was about the syntax score in these patients, the patient that performed the second procedure, like a stage procedure. At the first coming, they had a syntax score about 27, and when they come to place a syntax Axxess stent, their syntax score was 13. What does it mean? For example, this is the patient, one of the interesting patients with anterior infarction, edema, pulmonary edema, intubated, angiography, right coronary artery occluded, intermedius branch occluded, circumflex artery with a stenosis, bifurcational stenosis of LAD and diagonal branch, and acute occlusion of the distal LAD. So very, very high syntax score, 41 almost. So we performed during the first access in the hospital angioplasty on the LAD. We reopened the distal part of the LAD without touching the bifurcation. We reopened the intermedius branch and POBA on the circumflex artery. Then we placed on the second coming in the hospital ICD because of his low ejection fraction. And when he came to put the Axxess on his LAD, he had a syntax score about 16. So this is the placement of the Axxess. I'm not going to enter in the technical characteristics of the stent because it's not a matter of my presentation, but you can see how placing of the Axxess needs time, precision, and a little bit more contour. So at the end of the procedure, he had a syntax 8, residual syntax 8 for his right coronary artery. The distribution of our patients according to the artery was circumflex artery in 55% of the patients, 35% LAD on the diagonal branch, and 11 patients on the right coronary artery. Now we are doing also Axxess in the setting of acute myocardial infarction because some interesting characteristic of the stent when the occlusion is in the bifurcation, because it's self-expandable, continues to expand, and the problem with post-dilatation and distal embolizations is less present in this type of setting. About the access side, obviously at the beginning most of the patients were treated by femoral approach because the stent needs 7 French catheter, then we passed to the sheetless catheter, the radial approach, so now we are doing to the sheetless radial approach placing of the stent, so 40% were by radial approach, now the more. Some characteristics about this type of stent, which is a little bit impeniative, let's say, as a procedure. The X-ray time is about half an hour, the procedure time was about 130 minutes. The contrast is a little bit high. We use a lot of contrast, 300 milliliters, even more if you put the standard deviation, because, well, to place the stent you need to continue to inject the contrast. Obviously, this is the matter also of the experience, and increasing the number of the patient, you get more familiar. Even sometimes we are placing now access even with 1 wire without using 2nd wire. The variables about anticoagulation were Hendrix and heparin equally distributed. Interesting is, because it's a new stent, about the material used in this type of patients. Wires, 2-3 wires per patient, which is not more than a normal bifurcation that we are using in other techniques. Balloons, 2 to 5 balloons, no cutting balloon. And the type of access that you can see here, interesting is this number, 40 and 30% access that is 14 millimeters, because at the beginning it's advisable to use a longer access, because when you open the access you have to reposition it several times, back and push it. So if you use 11 millimeter stent, the time and the space that you can open the stent is very short, so you can leave it somewhere which is not its exact place. So it's better to the beginning to use a 40 millimeters stent. That's why our numbers are more about the 40 millimeters. The distribution of the type of all stents access, only access on the vessel 45%, access with 1 death on the main branch in 3 patients on 50%, side branch other 4 patients or 20%, and access pure other plus other stents on side branch and main branch other 4 patients. So totally we have 20 access, 15 deaths, and per patient we have 1.5 stents per patient. What does it mean? It means that access is a good stent to take into consideration when you decided not to use provisional stenting, but your decision is to do some complex procedure, when maybe you think that you have to put 2 stents. Results, very quickly going to the results. Procedure success 100%, and you can see here the same patients that I showed you at the beginning, at the final result. Device success, we are going here to see the device success, which was 90%. But what means device success? For example, in this patient with this bifurcation, my access was gone over the bifurcation, the LAD, so I had I consider it like a stent placed in the main vessel, so I put 2 absorb stents on the main and side branch, and as you can see here, the result was good. So I controlled this patient with IOS FFR, and the result was so good that we will present it at the next PCR as our case. About the complications, 1 patient, this is the access stent in his LAD, and you can see here inside of the stent there is a hesiness, which is acute thrombosis inside of the stent. So obviously Reopro and balloon, and here after the dilatation you can see some migration of the thrombus. Well, treated several balloons, at the end the result was good. Maybe here distally there is some distal embolization of the vessel. At the end, what can I say? Well, I'm almost at the end of my presentation. So the stent confers high success rate and low complications rate, and it's suitable for all type of bifurcation. I would say, especially if it's Medina 100 or Medina 111 when you are decide to put another stent. Now I can say also it's good also for 110, or 101 when the carina is involved. So this is with 1 stent you can resolve the problem. Well, it's about the device. device. I have to say it's a bulky device, but radial is feasible and easy, and with experience you can put it even in some cases even with one wire, so just using a 6 French catheter, which is not very advisable obviously, and needs precise placement, so needs good preparations. That's why it needs time and contrast. And the good thing in this stent is that if the placement is not optimal, well, it behaves like any other desk, as a standard desk, so you can continue on procedure as any other procedure on the bifurcation to do whatever you want. And last but not least, at the end of the procedure, when it's good, the result is really satisfying. And as I am living in this place, which is in Italy, the largest natural bifurcation, fan of the bifurcation, so I'll say thank you very much for your attention.
Thank you very much for a nice presentation. Now the presentation is open for discussion. Any question from panelists, please?
I have one question, and how many patients did you do pilot-sing alone after exit?
You mean post-dilatation?
Yes.
Well, I have to say that, well, almost 90 or 80%, much of the patient I perform a post-dilatation, because now maybe less because now I have experience, but at the beginning, you know, you're not sure that the stent is open, covers the bifurcation, you say, well, but there, and then I have to say that preparation is important, so we perform the preparation before the placing of the stent. So once perform the preparation, you put the access, you say, well, why not to do a post-dilatation? So at the beginning, I did many post-dilatations. Now I can say, for example, in the infarct patients, I'm not doing a post-dilatation. I leave like this. If the result is good, I say, if the result is good, I'm not doing post-dilatation. Because the stent, because also we had a follow-up, and I saw that the stent continued to expand, and sometimes you can see the stent at the first imaging, the first index procedure, and after 1 year, the diameter of the stent is bigger with respect of the first, so now I'm not doing post-dilatation if the immediate result is okay.
Could you tell me the limitation of using Excel? Limitation using
Access.
Axxess stent.
Well, the limitation, let's say,
experience.
For example, I can say if you start with the radial approach, you have the tortuosity, and your catheter pass difficulty with 6 French catheter, to change to 7 French is not advisable, so do your procedure with 6 French catheter and not place access, the first thing. The second thing is very important, is the angle of the bifurcation. If the angle is quite wide, the access cannot enter in the bifurcation, so it's not covering the bifurcation. Other thing is important, for example, I will say that the proximal, the main parent vessel, if you have some small branches that are coming near the bifurcation in the parent vessel, when you a little bit open your access in one of the branches, side or main branch, the angle must be good. You go back, and sometimes when access is open, the access enters in this small branch before the bifurcation, so should be a little bit attention to that situation, and maybe not to place access when you have some branches that comes near the carina, which is not strict written in the literature, but I had some cases that my stent stops before the bifurcation, entering in some small branches. Then you have to remove the wire from the main access wire and to put the other wire to try to go back to enter, even sometimes to put a balloon to change the position of the access. So these are but the most important design are also something else, the diameter of the vessel and the calcium of the side branch or main branch. If you have a very calcified main or side branch and you post-dilate, but still the images is not good and you don't have a good lumen, the access is not opening, so the access remains entrapped in the main or side branch where you put the access. So you put it in back, the catheter goes inside, and you can dissect the left main. But the experience, okay, after that.
Please go ahead with the question.
I am a little bit worried about the amount of dye you're using in your patient. You're using 300 to 500 cc in an average of 1.5 stent per person. What are the outcome of renal impairment, renal failure in those group of patients?
Well, first of all, the amount of contrast, not only you are, also I am a little bit disturbed about this amount of contrast, but I have to say these are the first patients. Then the first patient you inject contrast continuously contrast to position it, and also change continuously the projection to be sure that the position of the stent is correct. With the patient, passing the patients, then you catch some tips and tricks and you understand that you are in correct position, so the amount of contrast is much less now. This is the first thing. About the amount of the stents, well, I said, if your decision, this is as an advice also, if our decision is to do provisional one stent strategy, and if the patient is not 1-0-0 where one stent strategy access is okay, if it's not like that, your provisional stenting, do provisional stenting. But if your decision is that maybe this patient is suitable for crash, mini crash, TAP, whatever is else, then we can take in consideration access and maybe one other stent. So 1.5, it's not so much for a bifurcation, which is not a simple lesion. That's why we have so many symposiums and congress about the bifurcations.
Any other questions? Thank you very much.
Thank you very much.